This is the latest in a series of discussions about aspects of improvement science organised by the Health Foundation. Our topic today is technology, and the question we'll be exploring is, can technology really help improve healthcare? I should say that although we're focusing on healthcare, the field of information technology is obviously booming in supporting general health and fitness. My name is Bill Lucas, and I'll be facilitating our discussion. With me are two expert presenters. Dr. Brian Robson is a GP and Executive Clinical Director at Healthcare Improvement Scotland. Brian will be drawing on his experience as a Health Foundation Quality Improvement Fellow, where he studied the use of technology in high-performing healthcare organisations, and also his experience on the Scottish eHealth Strategy Board. Brian, great to have you with us.
Nice to be here, Bill.
And Tony Cornford is Associate Professor in Information Systems at the LSE's Management Department. Tony will be exploring the potential and challenges of digital innovation in healthcare, one of his acknowledged areas of expertise. Tony has a specific interest in the evaluation of e-health and in the implementation of e-prescribing. His latest research is in the area of digital drugs. Tony, welcome.
Thank you very much.
In a moment, I'll invite Brian to start our discussion. But before I do, let me remind you that these webinars work best when they are truly interactive. So in other words, we need to know what you think about technology in healthcare. Is it the way of solving all of our problems? An expensive distraction? Somewhere in between? Something completely different? Do please let us know by sending us your comments from now onwards. After our two expert inputs, I'll do my very best to put your comments, ideas and questions to Brian and Tony. So, without further ado, let's get started. Brian, tell us how we can bring the worlds of improvement science and health IT together.
Thanks very much, Bill. Well, let me make a start. I'm going to describe to you that the arguments are that healthcare in the 21st century is too complex for humans to provide alone. I'm going to share some examples through some patient stories of how health information technology can help us. And finally, I'm going to be, and perhaps throughout the whole talk, trying to persuade you that quality improvement professionals need to be curious about the possibilities for health IT. And I'm delighted that the Health Foundation have taken the opportunity to include health IT in this series of webinars. Let me take you to my practice. I'm a general practitioner. Tomorrow I'll spend time with my patients. This is Sam. Sam is a 7-month-old baby who came to see me a few weeks ago with his mother. And you can see that Sam and his mother and I are in a typical consultation, but also you'll notice there's a third element to that consultation. What has been described in the literature as the therapeutic triangle, including the computer. The computer is no longer an added extra, an optional extra, or something that you may or may not use. The computer is essential to providing everyday care. As a general practitioner, I've been using computers in my practice for the best part of 20 years, and I couldn't operate without them. But let me start with a patient story. This is Agnes's story. This is Agnes. She's a 79-year-old lady. She's well looked after at home by her husband and an extended family. And she has a great GP. That GP has included all of her medical history on the electronic system used in the practice. So you can see from that that Agnes has a number of problems, not least that she has a degree of cognitive impairment with dementia. But she also has these two other conditions, urticaria and angioedema, so allergic reactions of the skin where the skin swells up, or when it's serious enough it affects the breathing. And in fact, on 2 occasions in the last couple of years, Agnes had been admitted to hospital with severe breathing difficulties as a result of taking some medications. You can see on this list extensive list of medications. And at the bottom of that list, you can see non-steroidal anti-inflammatory drugs, things like Brufen or naproxen, and Agnes had taken those inadvertently. And also at the bottom of that list, aspirin, a commonly used painkiller which again, Agnes had taken inadvertently over the years, causing her urticaria. In Scotland, we have the Emergency Care Summary, the ECS, an electronic system for capturing all of those aspects of information about Agnes's drugs and allergies that's shared and accessible by other GPs, by the accident emergency system, by the hospital system, and by the ambulance system. So we have that information within the information technology systems in Scotland. However, unfortunately, Agnes was admitted to hospital with chest pain. And when she was admitted to hospital, they weren't sure what was going on, which is commonly a common situation. And when she was admitted to the ward, the staff noticed that Agnes was complaining of a headache. So they gave her 2 tablets for her headache. They are the oblong tablets on this slide, paracetamol. However, because it was a very efficiently run unit and because she was admitted with chest pain, she also got aspirin. And that caused Agnes's face to swell up, it caused her tongue to swell up, and it caused her to have a prolonged admission to hospital. So the inadvertent use of aspirin caused Agnes to have a prolonged admission to hospital. And that caused a complaint from the family that felt that if the information was on the IT system, why didn't the hospital use that? It added to their lack of confidence in the local healthcare system, and it caused considerable concern, not least for her son, because Agnes is my mother. Now, when we raised the issues with the local healthcare system gave us some responses. They gave us these responses. We asked your mother, and she said she wasn't allergic to anything. Not entirely a reliable approach to patient safety. Our ward pharmacist looks up the emergency care summary, usually the day after admission. Again, not particularly useful for Agnes or other patients who are getting medication in the first few hours of their admission. The third point here is an interesting one, and we may get into this discussion. This was a point made by the medical director of that system, who said he wasn't sure that the emergency care summary was accurate anyway. So he was clearly sending that message not just to the family, but I'm sure back at the base to the other doctors and nurses and pharmacists within his system. And finally, and the least reassuring of the responses, was that they would put a note in her paper record. None of those things were very convincing to us as a family, or to me as the medical director of the National Quality Organisation. And if you look at the words of Michael Porter is very clear. He says if you try to apply information technology to something that's fundamentally screwed up, it doesn't help very much. The message being you need to sort out the systems of care and not just add IT into that. And it's also not just about the knowledge of the healthcare professionals. Everyone knows this face. They know Dr. House. When I've asked people in presentations around the world about Dr. House, they all recognize him. When I ask them, do you want him to be in your team? They say definitely not. We do want the knowledge that Dr. House has. He's an amazing diagnostician, but we really don't want him in our team. But it's not just about the knowledge inside our heads. This is a schematic from Bill Steed from the Vanderbilt Clinic when the Blue Ridge group were reviewing the role of health IT in the healthcare system. And the schematic sets out that the amount of information that's coming in is way beyond the information that humans can actually compute. And as you get towards the right-hand side of that slide, as we start to introduce genomics and we start to introduce bespoke medicines based on genome sequences, it's way beyond the human cognition. And I'm sure that Tony will bring that up later on. But I'm a great fan of Homer. That's Homer Simpson. And one of his most notable quotes is that every time I learn something new, it pushes something old out of my brain. And that's true for all of us, no matter how smart we are. Let me share with you one more story. This is Hector's story. Now, back in 2009, Hector's provider was sending out text messages to remind Hector about an appointment that was coming up. Now, this is amazing technology, but this is not a new technology. The first text message was sent over 30 years ago. But still, it's good to see it being used by providers. The interesting thing is that this provider was the dog groomer. This is Hector, my dog. This was a text message from his groomer in 2009 to remind Hector of the appointment that was due. This is the practice where I work in Mearns Medical Centre with a great team there. And this team has invested in simple investments in technology, one of which is to get as many patients signed up for their mobile phone numbers to receive text messaging about their appointments. A full 4 years or 5 years after Hector's experience of getting his hair cut. But look at these data. Simple study done by Dr. Ireland and others last year showed that simply by introducing these text messages, we reduced our did not attend rate by almost a third. And when you add that up, it's about 3 weeks of GP consulting time. Really simple technology, used in other industries for many years, simply applied, and real impact. We're not alone and we're not new in thinking that technology would make a difference to the safety of healthcare. This is the famous report, the Crossing the Quality Chasm report from the Institutes of Medicine in the States back in 2001. It's more than a decade since they made this bold statement that IT must be central in quality improvement. And the question, I guess, is why does Hector's groomer apply IT quicker than the health system? But the health system has always been slow in looking at technology. Let me just read this out to you. This was a quote about a technology that it will ever come into general use, notwithstanding its value, is extremely doubtful, because its beneficial application requires much time, gives a good bit of trouble, both to the patient and the practitioner, because its hue and character are foreign and opposed to all our habits and association. This wasn't text messaging, this wasn't the laptop, it wasn't the computer you saw at the beginning. This was, in fact, the stethoscope back in 1834. So the healthcare providers and healthcare professionals have been somewhat resistant to the use of technology for longer than just recent times. This is another one of my patients. He was kind enough to show me and allow me to show you the technology that he's using to monitor his weight. He also has a similar app to monitor his blood pressure, which captures information from the ambulatory blood pressure monitor he bought from Boots the chemist for less than £50. He connects that into his scales in his bathroom, which also, through simple Bluetooth, send information to an app. That total piece of kit cost less than £100. It's been so useful for him in monitoring and sharing information about the things that he can do to improve his health condition. So the issue here is not one of technology or whether the expense of technology. To a large degree, in my experience and from what I read and from what I saw during my fellowship, it's about culture. And this schematic where the patient's saying, "Doctor, I want to choose how I'm treated," and the doctor says, "You're not just ill, you're deluded." So are we really putting patients at the front of healthcare? Patients are ahead of us in putting technology into their care. And this is a wonderful book. If you have to read one book on health information technology, the warts and all, the highs and lows of introducing technology, read Louise Liang's book of the 30-year history from Kaiser Permanente. Don't be confused by the title. It has nothing to do with the English Connecting for Health program. But this is Andy Wiesenthal. As part of my fellowship program with the Health Foundation with IHI, I interviewed Andy Wiesenthal, who was responsible for, along with others, responsible for the implementation of the Kaiser IT system. And this was an amazing quote that he gave me. Kaiser Permanente has reached a strategic decision that health IT is front and center of our business. I wonder how many healthcare providers in the UK, including Scotland, could actually say that and mean it. So in closing, I believe that there is plenty of evidence out there, both from the patients, from the experiences that we have, and from the literature, and Tony will cover some of that shortly, that if we bring the worlds of quality improvement and the world of health IT together, then we will radically improve the quality of health and healthcare in the 21st century. So I gave you these theories, these propositions. 21st century is too complex, whether it's the Homer Simpson or the Bill Steed or the many cases in the literature of an overload of information on the healthcare professionals. I gave you some examples where health information technology may help. Most of them from patients themselves or from other industries, including dog grooming. And I really do want this series and other aspects of the work that we do with the Health Foundation and others to bring quality improvement professionals to be curious and be involved about the possibilities of improving healthcare using or supported by technology. I'll leave it at that, Bill. Thank you very much.
Ryan, thank you very much indeed. Just for a moment there, I was rather wishing I was your dog Hector, who clearly has a very important role in your life, as well as your patients. So now let me ask Tony to give us his perspective and find out whether digital technology can help improve healthcare. Tony.
Thank you. I'm going to try and answer the question we're here facing: can technology really improve healthcare? And I'm used the word there, digital. We're used to the ideas of health IT, but I think it's the digitality, as you'll see, that maybe is the central idea we need to deal with. I can sort of give a slightly more downbeat version to what we've just heard. Certainly information technology is the common stuff of health policy. Whether it's always well conceived or not, we would have our opinions about. I think it's sometimes presented as a panacea, and the evidence behind those suppositions may be good sometimes. It may be tolerable on other occasions, and sometimes, frankly, missing. I think if we look at the way it's discussed in the popular press and in the specialized media of healthcare, health IT is often depicted as a scene of struggle. There's a lot of disenchantment. There's quite a lot of regrets and recriminations associated with many projects. Not all, I understand, but still we haven't quite got our feel right for this technology. Meanwhile, as we've heard earlier, it's moving on in other contexts, in the context of the patients and the lives they lead and the way that they imagine we should be using it. And certainly we keep coming back for more. All that struggle and disenchantment hasn't actually driven us away from it. We do seem to come back determined to keep trying. So the question we're here to answer has my answer, which is yes, but, and the buts I want to talk about, first of all, are our motives and expectations when we get engaged with health technology. Second, the model, the underlying understanding we have of it when we approach and fund and become engaged in these things. And third, the degree to which we are prepared for the degree of change that I think it will, with time and with effort, bring into healthcare. So first of all, motives and expectations. Most projects start out in a rather prosaic way with a business case. One has to sort of say what one's spending money on and why, and how one thinks it's going to work. And typically, for most projects, I think, it's about something like fixing today's problems. We're applying technology to try and solve an understood or known problem. We have some current practices, and maybe technology can help us enhance them. Incrementally, worthwhile, but it's a somewhat limited expectation. We also sometimes use technology in an attempt to make ourselves more efficient or smooth the current workflow. That's useful, of course. We usually put these projects and these initiatives inside our current organizational structures. It's much more difficult to initiate a project that's going to blow apart organizational structures, and it's more difficult to arrange the money and so on and such like. So those problems keep us perhaps locked in a little bit. And I think also we often respect and even reinforce our current professional and social demarcations between doctor and patient, between doctor and nurse, between specialists, and so on. And maybe sometimes that's something we're going to have to get used to giving up on a little bit. So if we talk about that kind of an approach to technology, I think we could fairly call it an instrumental view. Technology is a tool. We can use it to crack a problem that we face. We can make things quicker. We can make things maybe safer. I say on my slide there by circa 5%. I think perhaps some of your figures suggested a bit bigger percentages than that. But still, safety is not, it's a tricky problem, but almost by definition, and it's not going to be solved in totality by technology or perhaps anything else. We may make things cheaper if we're very, very lucky, but I don't think there are many health IT projects that have made things cheaper. More consistent, that's a possibility, but that comes with some problems. More joined up, we've said that's hard to get outside institutional boundaries, and in a way that patients notice and approve of if you really try. Getting the patient into our health IT, difficult. Easy to say, and I think quite difficult to do and to sustain. I think there's another view we might take of technology, and I think it's the view we have to get used to. I'm not trying to proselytize here, but I think it's a view which would help us go forward, which is to see technology as an opportunity for change. Not to solve a problem, but to reshape the whole system or the way we approach the task on a bigger scale. So we may be wanting to use technology to change what we do and the ways we do it. We may want to change where we do it, in location, in scale. Some things may be better done in small packets. Some things may be better done in very large centralized facilities. And we have to think about that, and maybe technology can serve both directions. The timing and the way we expect the scales under which we expect things to operate, and the connectedness. We also, I think, need to think about change in terms of the people, the institutions, and how they're involved. It's another facet of breaking out of the institutional boundaries. And also, I think, in the kind of value or benefit which we seek. I think traditionally we've tended to seek one or two specific kinds of benefit. There are more kinds out there that technology might be offering us, and if we woke up, we might be able to capture. And if this is our perspective, our motive, then maybe it requires a different view of technology. And I call it a constructive-destructive view, because one of the things I want to talk about or emphasize or introduce into the discussion at least today is the idea that technology doesn't just improve what we've got, it may create change on a scale where some things are destroyed, some things are discarded, some things are no longer done. And that's often quite hard to face up to if it means that somehow the world we live in or the health system we use is not going to be quite the same as it was before we started with the road of technology. So this is the kind of a perspective on technology where we are releasing new forces to drive significant and reflexive changing. I use that word changing, which is a slightly strange English usage, but it's the present participle of the world. It's ongoing change. When ongoing change happens, we're changing. And in a sense, technology can loosen up healthcare and introduce it to an idea of ongoing change rather than discrete episodes of improvement change and then some sort of freezing once we achieve what we're looking for. We talk about practices. In this case, we may be changing practices, structures, responsibilities, patient kind of experiences or choices or behaviors. These are the kind of things that we might set in motion. And my argument would be this kind of an approach goes a little bit beyond improvement, which tends to start with a baseline and then measure some delta on that baseline, the degree to which we've improved, to delivering something completely different. The word that's sometimes used in the health literature is transformation, though it means different things to different people, but it may be a good word to bear in mind. We're interested in transformation rather than in improvement in the narrower sense. My second idea is we need some new models. Well, here are two newish models. I can't say they're totally new, but I think they're models that are gaining a little momentum and traction. And the first is the logic of delivery. The project, the traditional project, is probably not the logic of our delivery these days. For many people, we're more interested in working out our systems as they are being used. Of course, you have to do some preparatory work, but once the technologies enter into use in a healthcare situation, they're encountered, they're appraised by people, and people get to work wondering what they can do with it, what they can't do with it, the things it was supposed to do, and the things, surprisingly, they find it can do, but nobody told them about. So systems grow in their context of use. The timescales for this are naturally extended, and for a good reason. It does take time for that kind of a process to take place. It's not the 60 days of the implementation plan. It's the 2 or 3 years as people perhaps get the most out of what they're given to work with. Over time, then technology normalizes. It becomes the way we do things around here. And it becomes usually achieves that status because people work at it. They're committed and they put in their own effort to make it work. And anybody who's studied an implementation in a hospital ward will see people working hard to make it work. In the beginning, very hard. But as time goes on, perhaps the work becomes more natural, but it's still there. Systems have to be worked up. And the result is something specific, distinct, valued, different from the initial plan, but something we should celebrate. When it works particularly well because it is owned and located. The second idea of a new model is to think about digitization. Here's a quote from an academic author in a recent publication. What do we mean by digitization? The encoding of analog information into a digital format and the possible subsequent reconfiguration of that. So context, once one's done that. We've seen this in music, we've seen this in media, we see it to some degree in the transport industry, where technologies digital technologies have led to complete restructuring of the way we work in that industry, or customers or consumers of that industry. The digitization is going on in health. We haven't got yet the subsequent sort of reconfigurations, perhaps on the scale which I'm proposing we might have. Digitization takes place in different ways, and people watching this webinar, I'm sure, are familiar with the idea of objects which become digital when they were analog, with representations that become digital when they were maybe on paper, or maybe they didn't exist at all, or maybe they were in textbooks, and on routines, algorithms and things that take over or work with us in healthcare to try and structure our tasks as we go along. If that kind of transformation starts to gain momentum, my argument would be it's going to be disruptive. We're going to find that quite a lot of what we've taken for granted is going to be put in question. The American economist Joseph Schumpeter, whose picture is here, coined this phrase, or used the phrase, perhaps he didn't coin it, creative gales of destruction. Technology leads to innovation, innovation leads to change, change leads to some things being destroyed or discarded, and we must be prepared for that. It's essential to progress, but we must be prepared to live through that kind of a period, and I think we need to talk about it and not assume our way out of it. The consequences, the kinds of consequences which I'm talking about is the way in which we structure our data and our services, the extent to which we work through small local apps, the innovation end of it, and the extent to which we build infrastructures and resources, platforms, if you like, upon which we can rely for that kind of an application of technology. Tasks, of course, are going to be built around that new kind of architecture, just as they are when mobile phones, where we have the Apple Store, as it were, the platform, and the app is something we choose. I think these kinds of technologies will change processes and workflows in terms of scale and time and so on. There'll be economic consequences coming out of that, network effects, and again, challengingly, new opportunities for control, for surveillance, for real-time data use, which we face in other aspects of our lives, but I think healthcare is going to have to face up to too. So, my last slide, just to reiterate my answer to the question, yes, but the motives and expectations that we have for technology should look beyond improvement towards system-level change. I think that's important. Delivery, more by the design in use and the working out built on top of core digital infrastructures. Digitization at the scale it's starting to take place in this country and in many others is probably suggests this is all going to have quite a lot of structural consequences, and we need to be there and help shape them as we go into the future. So that's my contribution. Thank you very much.
Tony, thank you very much. A wonderful compliment to Brian's contribution. Now, interestingly, thanks so much for the comments you're sending in already. The vast majority of them are not about technology, but they're about the theme that's been sitting in both of your talks, which is change. How do people adapt and use this? And I got a very specific one, Brian, which is sort of aimed at you, not personally, but I think it speaks for a number of us. And it's very simple. It's from a colleague in Manchester. Why are healthcare services so slow to adopt new technologies? So no pressure, Brian, but why is it taking such an incredible amount of time?
Well, it's a great question, Bill, and I think the questioner puts it very well. We have perhaps an oversimplified thought around how technology could be introduced. So I wasn't making the point that because Hector's groomer can bring in technology, we can bring it into our hospitals and our GP practices. The point is really that change has to happen, the system has to change, and then you bring technology in to support that change. You don't change simply because of the technology. But if you were to ask me, there's something in there about leadership and having leadership being committed to using all of the tools, all of the infrastructure, including technology, to support change, for the leadership to be familiar with technology, so to be experienced. How many chief medical information officers are there in the UK? There are some, but not many. In the US, every major institution has a chief medical information officer. Whether it's a doctor or a nurse, that's irrelevant. Somebody in a senior leadership position who knows about technology, who can actually support the senior decision makers in actually investing in it. And I'll just close off just on one third point. The third point is you have to, into Tony's evidence base, you have to be prepared that it takes time. It's not a one and done, it's not a plug and play. You have to be prepared for the long haul. And that involves preparing your staff, the board, the politicians, the finance people. It's not a one and done project. So if those three things were, I would say they were the three things in my experience that would be important. Leadership knowledge, and be prepared for a longer implementation and return on that investment.
So if the human race is by and large quite impatient,
sure.
How do you get over that? I mean, you gave us some lovely examples of your GP practice,
Yeah.
and they seem very straightforward, very simple, and sometimes led by a patient.
Yeah.
How do you get the right scale of technology to persuade someone that it's sort of worth the wait because it's going to have a big impact on the service or patient user's life?
So I guess there's something about sharing those examples, reassuring people. So again, a question for our listeners, viewers today and for others would be, you know, if that simple technology around prompting people around their appointments, how many practices have that simple technology? You know, it's not past the 50%. It might just be at the 10%. So there's something about sharing those examples and encouraging just at small scale. That particular product costs less than £50 a month, that particular product. You know, but people are nervous about it.
Yes.
They needn't be. They need to hear it from their peers. And it's not about the big academic units. It's one thing to understand what happens in Kaiser Permanente or even, you know, UCLP here in London. But it's another thing to actually just have your peers sort of say, look, I felt exactly the same as you did, same concerns, this is how we did it, and have some form of facilitation to help them test it out.
Okay, thank you. Tony, you were going further. If I heard you correctly, you were saying that not only is change complex, but we should expect it to be disruptive, and we should see this potentially as part of the solution. Was I hearing correctly there?
To see destruction as part of the solution is...
Disruption, I said, perhaps.
Disruption is going a bit far. But I think the logic of technology, I think my argument would be the logic of digitization would be these things are going to happen. They probably are going to speed up. They probably, the technology itself has a power to force itself upon us. We've seen it in many other industries, and I think we have hesitated in healthcare, probably for good reasons. My answer to the direct question would be the reason we've been slow is because medical professionals have been doing their job. They're meant to do no harm. They're meant to think safety first. And that's why we go slower than dog groomers. And I think that's the way it should be. It doesn't mean to say we shouldn't try, and it doesn't mean to say we shouldn't achieve things. But I think we shouldn't worry too much about somehow that Tesco's got barcodes and we haven't. I think that's kind of the wrong way to think about it. I think we've got to think about the dynamics of healthcare itself and the things that inhibit and the things that promote. And sometimes that time is a good thing. If you take the time, resource the time, expect the time, don't get impatient through the rocky first 6 months, you may achieve a lot more. I think sometimes the impatience can kind of derail projects before their time.
I'd like to come back on that, Bill, because I think to agree with you, and that those changes can take time. But let's use the barcode example. So we think, in general, intuitively, that if we were able to barcode a drug and go to the patient's arm and check the barcode on their wrist in the hospital, you would be able to reduce patient administration errors in prescribing. And it's true, that's what the evidence shows. But in reality, what happens is, if that technology isn't simple enough to use, what the nurse does is she gets a bit of paper, she takes all of the barcodes and she sticks them all on a bit of paper, and he or she then clicks on that, walks into the room, gives the patient the drug. So if we don't plan to make it as easy as possible for the humans to use the technology, they will work around and introduce error. Not because they want to, because we've not made it as efficient for them.
We had an even better example where barrier nursing, you weren't supposed to take trolleys into the room. So the trolley with all the smart stuff on couldn't go in the room, so the barcode was stuck on the door jamb. And the patients cycled in and out of those rooms quite fast, and whether the barcodes got changed, technology does take time to get those wrinkles out. These are the things you can only find out about when you actually implement it.
No okay, this is great. We're getting into the detail here, and don't want to frustrate the flow at all. But there's a really great question here that's going to pull us up a bit and pull us back a little bit from a colleague in the Netherlands. And just a reminder to us that perhaps we haven't defined what we mean by healthcare and the full variety of settings, although we've mentioned a couple, maybe three, and also what we're encompassing in the word technology. So would you mind just going back up to the head of the river, Brian? And when you're talking about healthcare, what do you mean by that? And again, similarly, in terms of technology, what's the range that you have in mind?
Okay, so if I try this, so in healthcare, I'm thinking patients with a healthcare problem, that they deal with a healthcare provider, whether it's a doctor, a nurse, a pharmacist. So it's not about health of the population, it's not population health, it's an illness type approach. But from a technology perspective, that could be everything from the actual technology, the actual information technology that I use when I prescribe in my practice for the patient. And I get the drugs and it prints off, and I give the patient the paper slip, or it goes electronically to the pharmacy. The next stage back from that would be the discussion, Mr. Smith that had the app. He brings in his own information. We discuss the information he's bringing to that, whether he's got diabetes and we're discussing his blood sugar, or whether it's blood pressure, or whether it's weight. And then back again from that, I would consider health information technology to include information about conditions, the sort of thing that NHS 24, NHS Inform, NHS Choices allows information. And then back again from that, I would include some of the Fitbit type activities, or some of the technologies at home, further away from the actual clinician, but nonetheless important. Or it could be the telehealth and telecare type technologies. And then further out from that again, in my view, it's about what do people self-serve? How do they get their own information? How do they use it? How do they use Fitbits? And never touch the health service. Okay, that would be my kind of range.
Really helpful. Tony, how would you approach those questions? Sort of.
I would say, with my academic hat on, I'd say I'm interested in technology as a stuff in the world around us. We know when, in a sort of everyday sense, what we mean by technology. We mean hardware and to some degree software, and we mean the services and the the functionalities and the capacities that it embodies. Now, in that sense, I would include pretty much what you said. I'd just come at it another way. I'd say mobile phones, smartphones, and the app stores and the app environment and all the services that apps tap into are, as it were, technology. They're a chunk of potential that can be appropriated in different ways by different human beings or groups of human beings to serve their interests and needs. So, I'm interested in it, in technology. In my slides, I use the word technology. In the title of this, we use the word technology. And to me, it really does mean something. Technology is almost a force out there in the world, and it's a force which has gained quite a lot of power in the last, let's say, decade. It is more influential in the way we do things in our lives, all manner of things, the way we gather our news and information. I don't know if you buy a newspaper every day, but I don't. About once a week now, and I'm probably the prime demographic to buy one every day if we went back 15 years.
Okay, let's stop there, because that's a really interesting point too. Two questions which I'm going to combine now. One is, actually it's pretty clear, it's suggesting that healthcare professionals simply don't have the, especially the demographic you're talking about there, Tony, the IT knowledge themselves in their own lives to be able to apply it in their professional life. That's the first question. And related to it, which is sort of implied in the way you were talking about your relationship with your patient, Brian, how is technology, or is technology, changing the relationship that the healthcare provider, the individual like you, the doctor, the GP, is having with his or her patient?
So it's a great point. So there are a couple of points. Let me try and answer the second point first. So the point around changing relationships. I already see changed relationships. They were real patients that I shared their stories with their permission. And so increasingly we're having informed discussion, informed by some of the information which patients have accessed or some of the data that they now have at their beck and call. So we're having a more informed discussion, whether that's with the patient, a family member, or just because we're bringing the information together using technology. But I'd like just that there's a particular transformation happening in the United States, and it's called Open Notes. And you'll be able to find it, just Google Open Notes. And a wonderful professor of primary care at Harvard, a chap called Tom Del Banco. And he's been telling us about this for a few years now through the JAMA and through New England Journal publications. But what happens there, Bill, is that they started with 20,000 patients over a number of different practices, and they allowed the patient to access the consultation, the information about the consultation notes. And so they called it Open Notes. So the clinician saw the notes, created the notes and saw them, and the patient did so also. And it's astounding. There was concerns from the doctors. 50% of the doctors said, oh, I don't want to be involved in this, but I'll give it a shot. At the end of the pilot, none of them want to stop. The patients have expressed that they are much more confident, more than 80% more confident in terms of their healthcare, understanding their healthcare. And important things like drug compliance has significantly increased because they've had access to the information, they understand the rationale for prescribing, and hence they're more interested in taking their medications. Now, they're now testing that out over 20 million population in the US. And here in the UK, we have got little pilots of people being able to access some aspects like their prescribing record or their appointment record. But where are we trying this ability for patients to actually not co-create the notes, but understand and get the most out of their notes? That's a transformation in the relationship between doctors in this example and patients.
That really is transformation, a bit in the sense that you were using the word, isn't it, Tony?
Yes, I think it's a good example of that. I'm always a little worried with the idea that there is a sort of very strict age gradient, that some people get it and some people don't. Clearly there's some sort of a gradient there, but I think we can trap ourselves by taking that gradient too much as a sort of a given. Some of the most innovative users of technology I know aren't young, and some young people are.
Well, that's because of the people you hang about with, Tony. I mean, in general, I think there is this gradient. But if you look at the kind of middle group,
If I'm allowed another anecdote.
Please do.
This is a social party talking to somebody about their new GP's IT system and IT booking system. And somebody over 80 told me, it's fabulous. I can see the GP anytime I want. They release the new slots for the next day, the ones they keep back, at 2 a.m. in the morning, and I'm always awake. So I can log in at 2:15 and I can get to see the doctor anytime I want. And I just thought it was a wonderful example of how somebody, had integrated technology into, they found the wrinkles. They were working it out as
Very
a patient.
good.
Although, of course, that brings this digital exclusion into
people who sleep get excluded.
People who sleep get excluded. Yeah.
Very good. So now I wouldn't be doing my job if I didn't raise something that it's raised in the questions. You touched on it, but forgive me, you both sort of slid over it, which is the issue of cost. If we were opening our newspaper in the last decade, we'd see some variant of a headline, either a tabloid or in a serious journal or newspaper that says, what a waste of money. We spent an awful lot on something, some big IT project, and it gave us precisely zero. Am I being unreasonable? Is that an unfair voice? Or what's your view on that, Brian?
Well, I'm just going to drink my water and allow Tony to answer this question first.
Tony, what's your view
Tony
on
from
that?
England.
From England, yes. I think it was aimed at me. Well, my personal view is it's wrong to see it that way. I think a lot was achieved. And I think the media do us no service. And that's probably because we don't talk to them enough and explain things enough to them. If we think of England's big national programme, most of those projects still exist. Most of them delivered usable and used services. Not all of them, and God knows there are lessons to be learnt from it. But it takes time. It takes time. And if you launch these things with politicians' unrealistic timescales, and then announce it hasn't happened by the next election and therefore somehow it's a disaster, I don't think it is a disaster.
Okay.
I think it's a mixed story, but we've got to be much more relaxed, I think, about what's realistic to achieve, whether we are learning enough from those experiences, and just how long it takes to make things.
That's very helpful. And I think, Brian, as you were sipping your water, you were possibly making a distinction between south of the border and north of the border here in the UK. Am I right?
Well, there are certain differences, that's for sure. I think the work that Tony and others have done in evaluating what's happened in England and elsewhere has been wonderfully helpful for the global community. Both in your publications and in your discussions, and how those lessons have been learned. In Scotland, we've taken a different approach, not because England was doing it a particular way, but we've always been small, testing things out. We previously had a phrase we used, allow 1,000 flowers to bloom. We've moved away from that over the past 10 years. We've now narrowed things down. We've a smaller number of suppliers now, so from 5 GP systems down to just 2 GP systems, for instance. 1 system for the electronic radiology system. So we've brought those things together. We've done it in a less public manner, so I think the national programme was always in the press. Private Eye gets read in Scotland, but I don't remember seeing very many articles about the Scottish Health Service in Private Eye.
Okay.
But I think we've learned a lot from England, so good on you for doing the work that you've done.
It's a fair cop. And I know that you've done some very interesting work on e-prescribing, for example, Tony. I mean, what are the lessons that we might learn from that?
Well, they are somewhat similar. I think e-prescribing, interestingly, it's a rather parochial issue. E-prescribing was not part of the national programme in England, but during the period of the national programme, well, it was supported, but at a very small scale, I should say, very well, but at a small scale by the national programme. But off their own bat, a large number, and I think by today, a majority of secondary care providers in England have electronic prescribing on a reasonable scale inside their hospitals. And they've done it because they believe in it and they want it, and they've, as it were, put their own money and resources into it. So electronic prescribing is it's not easy to do. It takes time and effort to do. There's a lot of work to make it work and so on. And once you're on that treadmill, that work has to keep going year in, year out as people are trained to use it and as new drugs come on and go off and protocols change and so on and so on. But I think it's actually quite a good example where we're actually got a good news story
Okay.
going, and we don't perhaps talk about it enough.
Okay, I accept that. Just want to shift the conversation into the topic that we're sheltering under is, of course, improvement science. And this is of great interest to us at the Health Foundation. I'm interested if you wanted to shine an improvement science lens or improvement of healthcare lens on this. What might folk at different levels of the system be doing if they're interested in making some improvement, either locally or regionally, or indeed nationally, to try things out, to take a little bit of this into their own hands? We talked about national programs there, but I'm as interested in your small tests of change that you were describing, Brian. What could somebody watching or listening actually do themselves right now?
So it's a great point. I would like to just answer that perhaps by drawing on the electronic prescribing in hospitals. Mm-hmm. We've been electronic prescribing in general practice for 15 years easily.
Have you?
Yeah. So when my patients come to see me tomorrow, I won't prescribe anything without some degree of decision support on the screen. Mm-hmm. So arguably, in hospitals, certainly in Scotland, where we've only got 2 hospitals with electronic prescribing out of the 38 or 40 large hospitals, arguably the sickest patients are getting the most significant drugs with only the knowledge between the ears of the prescriber in our hospitals. So Scotland, so to answer your question, at a government level and at a national level, we've agreed that we are going to, in the next 3 years, roll out electronic prescribing across our main hospitals in Scotland, because we've learned a lot from Tony's work, from Professor Aziz Sheikh's work, and we've committed to doing that because we recognise the benefits. Below that level, our organisation, Healthcare Improvement Scotland, has worked with others to develop implementation guidance, and we're publishing that work this month, May 2014. And Laura McIver, Aziz Sheikh, David Bates from Harvard has been helping us with that work, and again, drawing on the experience in England. So as a national improvement body, we are saying, actually, we can bring some really good knowledge to bear here. At a local level, it is about getting implementation support. So in the Kaiser examples, they talk about tiger teams. Expert teams that will support the implementation and learn from the previous implementation. Mm-hmm. So we're exploring in Scotland, how can we help people to implement well and learn lessons? But right at the very grassroots where the patients and the clinicians come together, it is about redesigning the processes. So if in improvement science, what's the method for that? Whether it's using lean approach to look at the workflow and cut out the waste and make sure, whether it's model for improvement, small tests of change, again, with probably without the technology, just with can we do this differently? And then only then working really closely with the supplier. Why would we just buy something off the shelf and think you could plug it in? You can't do that. You have to work with the supplier and get them to iterate small tests. Is it working in that one ward? Is it working in 3 wards? Is it working in 5 wards? So I guess improvement science all the way through.
Yeah, okay. Tony, any thoughts?
Well, I'd agree with pretty much everything I think you said. I think for individual people who have the opportunity to do, I would say we need to argue for those post-implementation resources where the learning and the consolidation happens. And I think we've got to argue for better opportunities to network and communicate experiences. What has struck me, particularly doing electronic prescribing studies in England, albeit a few years ago, was how each hospital's a little island. Right. And they could share so much, not just experience, they could share staff. An implementation period is when you need 50% more bodies available to you. And a few places could do that. They could sequence their sort of rollouts or whatever, so they backed each other up and supported each other. And I think it's giving some more resources to the post-implementation working out period, and it's trying to find better ways to share knowledge, but also share resources. It's not just about conferences and workshops and so on.
A big question, and then as we've got about another 5 minutes, we're going to overrun by 3 or 4 minutes. I'm going to invite you to choose something that you think is of particular interest to you and just tease us towards the end, something that's emerging practice. But here's an interesting question from a colleague about some of the ethical issues that this may raise. Are there ethical issues, and if so, what are they? And if we have some patients with access to technology, what are they? And some, therefore, without. And some patients who are using technology at home. What might be the kind of ethical concerns that might interest us? I'm looking at you both.
So
Tony, you go first for a change.
Well, clearly there are ethical issues. I don't think there's any doubt about it, and I think you're right. The ethical issues around inclusion and exclusion. I'm particularly interested in the intergenerational ethical issues. The ethics, let's say, of telecare of the elderly. If you, as it were, telecare a population to the point where their sons and daughters and grandsons and grandchildren are sort of excluded or invited to call the call centre and see that all is well, rather than call granny. And I think there's some ethics there that I think are quite interesting, and there's sometimes a rather naive way in which some of that telecare is painted, and these kinds of issues I think arise there.
Does that worry you? There's a question here about sort of the tail wagging the dog, really, that sometimes the technology seems to predominate rather than the patient or service user.
This could be the tail wagging the dog somewhat, and certainly you can hardly pick up a publication in this area which doesn't start out telling us we have a demographic change and a burden of chronic disease, and we're going to have to automate or streamline or do something to the sort of care of elderly people in our communities. And I think sometimes the technology is reached for rather as if it's the panacea, and I think it raises lots of issues, even if it works sort of out of the box, which it probably doesn't. So it's probably a lot of work to make it work, but even then I think we do have to think about those ethical concerns.
Ethical issues for you, Brian, I guess you've got both the national perspective and also the dialogue that you'd be having in your own GP practice.
Yeah, so I mean, I guess just to Tony's point, because we've got a hammer, everything looks like a nail in some occasions. So because we can get a smart house and smart technology and allow families to watch what's happening in houses, etc., we should do that carefully. My experience is that the people who are in that field do it carefully. And even the vendors, the people who are selling the equipment, are now very conscious of the fact, actually, this has to fit into the plan that the patients and the families want. But we have to look to that for part of the solution for reducing the burden of older people's care in the future. We have to look to part of that. But I'll give you a quick anecdote. So my mother, who I introduced earlier.
Yeah, we've met her.
Yeah, you've met her. We put a small camera on a wee table beside her, so that when we called, if she didn't answer the telephone, we could see that she was okay in the chair that she sits in all the time. 2 days in, my sister phones me to say, "Can't see Mum." And I said, "What do you mean, can't see Mum?" "Can't see Mum, she's put something in front of the camera." So I was going over anyway, so I went over to my mother, and there's my mother sitting there, and a packet of Kleenex tissues are right up against the camera. And I said, "You're not liking this much, Mum." She said, "I just don't want to be looked at all the time." So, but it's still very useful, but we have to be careful.
I like that very much. The human element comes through an awful lot. Thank you for the wonderful questions you've been sending us. Now, I'm going to invite both Brian and Tony just to give us one example of something that's really exciting them. And I've heard so many different ways in which e-health is progressing. I've heard it for prescribing, for communicating, for monitoring and self-monitoring, for the kind of health informatics we've talked about. And we haven't really touched on, but clearly a bigger issue about wellness and the monitoring and the proactive engagement with that. And of course, we've heard about Hector and a little bit too about Brian's mum. So, Tony, what's exciting you as we move towards close here? What's exciting you? What's sort of kind of leading edge thinking in terms of e-health for you?
Well, what's exciting me, because we're starting some research on it, is digital drugs. That's the name. That's to say, all the information systems, the myriad of systems which surround medicines as they are used. We're familiar with them individually. We've been talking about electronic prescribing, transmission of prescriptions, the supply chain, something we don't really talk about very much, but medicines come from somewhere and they reliably arrive in the pharmacy, we imagine, and they're in date and they're not counterfeit, they're genuine, and so on and so on. So all those kinds of systems, the kind of systems which will inform medical practice in the future based on the use of large bodies of patient data, so-called stratified medicine, and on all the possibilities there of using medicines in a much more precise way, choosing the medicine on the basis maybe of genomics, maybe of other health data about the patient or about the patient population or subpopulation. Those kinds of things are exciting to me. I can see a day when, not too distant, when we talk about a medicine, we won't really be talking about a molecule in a pill. We'll be talking about a very complex set of digital and algorithmic resources and services which somehow or other end up in the delivery of just the right molecule in just the right dose.
Great.
That's what I'm interested in.
Great. So digital drugs, you heard it first here. Brian, what about you?
So I guess just two things. So the first thing is, let's spread the things that work and do it now. William Gibson, the science fiction writer, once said, "The future is already here, it's just not evenly distributed." So let's distribute and get the implementation of those things that work and do it well and plan for that. But I think the big transformation will not be from professionals. I think it will be from patients, the public and the citizens. If open notes works the way that the early studies have shown, if our simple experiences, day-to-day experiences of how patients can get better informed about their care, make better decisions, better planned decisions, I think the big change will be when the public and the citizens start to push us as healthcare providers to actually get really into the field of using technology in a way that suits them. That will be person-centered health IT. Some healthcare systems are doing that across the world, and others, they've got to catch up.
Great. So, our time is now at an end. My thanks to Tony Cornford and to Brian Robson for a wonderfully stimulating hour. And huge thanks to all of you who have contributed through the wonders of digital technology. It will not have escaped your notice. Even for a moment we had to use human technology, did we not, to make sure that the show stayed on the road. All of us at the Health Foundation hope very much that you've enjoyed this webinar. Our next webinar will be on Monday the 7th of July. Its topic is resource allocation. Our experts will be Anita Charlesworth, Chief Economist at the Health Foundation, and Gwyn Bevan, Professor of Policy Analysis at the LSE. But to close today, let's give Brian and Tony one more large digital round of applause for their contributions today. Thank you.